registering and recording, and then you should be. Okay. Just
Yeah.
play.
Okay, cool.
Alrighty.
All right, let's start. So my name's Sally. I am a fourth year medical student. So I'm just going to run through the MSK OSCE today. So to start, I just kind of came up with like the things you need to know, which is basically directly from the clinical skills guide. Also, if you guys want the slides after, I'm happy to send them, so you don't have to take notes, whatever. So basically, top one, the general approach to a musculoskeletal exam is your look, feel, move. So that's going to guide all your exams as like your basic structure. And then the specific exams that they want you to be able to do is hand and wrist, your knee exam, and the MSAL, so the screening exam. What you don't need to know for phase one are like special tests, so extra tests of function of specific joints. And you don't need to know diagnosis. So I know like with phase one, there's often a lot of kind of uncertainty as to what you're actually expected to do in the OSCE. But if you kind of just stick to knowing your principles and that and not getting too caught up in all the extra stuff, that's the way you're going to really do well.
AV is all working fine?
Yeah.
Are you projecting from your laptop?
Yeah.
Oh, sorry.
Yeah.
No worries. Yeah. All good.
Cool. So just some like overall tips. So the first one is like describing the patterns that you're seeing rather than focusing on the diagnosis. So for example, in MSK, do you think this might be an inflammatory condition or a non-inflammatory condition? Is it something that's acute? Is it something that's chronic? Or is it acute on chronic? So an exacerbation of a pre-existing condition. And then your look, feel, move, and the function. So in like your history and your exam, one of the things that really comes up a lot in MSK is the impact of a symptom or something on the individual. So because with joints and that kind of thing can obviously really impact what the patient can do. So the example that they often use is like people can no longer play piano because they've got arthritis in their hands. So just really remembering in the back of your mind what is the functional impact of this on the patient. And then when you're examining, always examine the normal side first and always compare both sides in your patient. So we want to look for differences both in the patient and compared to normal. But your first kind of place to start is by looking at the joint on both sides in the individual and seeing are there any obvious differences there. And just as a general OSCE tip, in any of your histories and exams, gain consent at the start, but then do your exam. So what we tend to do in phase one is we kind of keep asking for consent because you kind of just, it's like the natural thing that you do because you're a bit nervous and whatever. But if you just like ask at the start and then just be confident and go throughout, like they've already consented to you doing the exam. So just like within reason, obviously, but yeah, don't feel like you have to keep asking. So I'll just briefly go over the history. So your four key presenting complaints that will come up for this OSCE is joint muscle pain, joint swelling, joint stiffness, and giving way and locking. So I'm not going to go through all of the Socrates because I think you guys will be probably pretty all over that and it's pretty much the same for all of your histories. And within each of these presenting complaints, a lot of the questions and things that you have to ask are quite similar. So I thought I'd just go through the top one. So with pain, characterization of the pain is really important. So someone says they have pain, you need to really drill down into what actually that means for them. So because pain can be different for different people, it can be different severity. What some people say is a 10 might only be a 5 for someone else. So really just like asking those questions and getting to the bottom of that and working out like, is it a dull pain? Is it a shooting pain? Is it whatever, rather than just saying they have pain there. Localization of the pain is the second thing. So figuring out exactly where the pain is. So especially in MSK, this can be really tricky and often in these kinds of conditions, the patients might not be able to describe it well themselves because especially with a lot of like muscular stuff, it's really hard to actually pinpoint the exact location of the pain. So just making sure you're really asking those questions or getting them to point to where they feel pain is important. And not that you'll have to like go into it now, but just to be aware of within that, they can get referred pain into muscles from joints and that kind of thing. So just really asking those questions. And symmetry, so is the pain happening on both sides? So say if it was a shoulder, is it one shoulder, is it both? And that kind of goes for anything, just working out where it's happening. The onset, so like I kind of spoke about before, is it acute, is it chronic, or is it acute on chronic? Was there trauma to the body part, or was it like a slow progressive onset and they don't really know why it's happened? Timing, when's it better, when's it worse, particularly with MSK, things like, is it for differentiating your inflammatory and non-inflammatory conditions, is it better after exercise, worse after exercise, or worse after rest? And with timing, is it better or worse in the morning and or at night? And we can kind of touch, I'll go into a bit of the differences between rheumatoid and osteo, and we can kind of touch on that again after. So yeah, that's basically, if you do those things as well as the other things that we kind of haven't discussed in Socrates, that'll be a good characterization of the complaint and what's happening. And you can kind of use those steps for all of the other symptoms as well. So I probably won't go into other ones unless anyone has any specific questions on the other three. No. Cool. So I just popped down the bottom some red flags. So basically, you probably won't really need to use this, but some red flags are good to know. Pain at night or waking from sleep, weight loss, night sweats, looking out for those signs that could suggest malignancy, especially with sarcomas. So they can often present with some of these symptoms, and with actual pain in the leg. Like there was like a case of like a 17-year-old guy, and the only thing he had was just like he came in with calf pain and then ended up being like sarcoma. And he like died within 2 years. So it's a really aggressive cancer, and often it doesn't have a lot of symptoms. So just keeping that in the back of your mind. And then the one is like back pain that's keeping you up at night, waking up from sleep is another red flag. Your key pathologies, phase 1, rheumatoid, osteo and gout. And then some other common symptoms, so sensation changes, which could be some like neuro stuff, loss of function or difficulty doing things, fracture dislocation, a gait disturbance, or systemic signs so extra-articular signs of arthritis. So they might be just like some of the things that your kind of histories will be, that's what the person will be complaining of within like these major kind of symptom headings. Okay, just really quickly, so past medical history, obviously you want to know if there's been any trauma, if they've had any past surgery, any like joint surgeries, any recent infections, so especially in young people, STIs, gonorrhea, I can give you reactive arthritis, and that can be acute onset and quite severe, so just screening for that. And psoriasis, so the skin condition, so you can get psoriatic arthritis, which can present with that. So that's good to ask about as well. Your family history, most common one, rheumatoid arthritis, AS is ankylosing spondylitis. It's another autoimmune arthritis, which has a genetic component. Your osteoarthritis, I put it there, osteo, obviously you'll ask about it, but osteo doesn't really have a genetic component, so it's good to just be aware if it does, but it's not really going to influence that much. Gout, other autoimmune diseases, so SLE and IBD, so just because, as you know, autoimmune diseases run in clusters, if they have other autoimmune diseases, it might mean they're more likely to have like rheumatoid or AS, so that's important to screen for as well. Yeah.
What are SLE and IBD?
Systemic lupus erythematosus and inflammatory bowel disease. Yeah. And then osteoporosis as well. And then I've just put some of the medications for some of those common conditions. Especially with elderly people, you might be kind of taking a history, and they'll say they're on these medications, but they haven't got a diagnosis or anything. So sometimes if you look at what medications they're on, it can give you a clue as to what kind of the problem might be. So for osteo, they might be on NSAIDs. They might have steroid injections and glucosamine. So glucosamine doesn't have a great lot of evidence for it. It's just like a supplement kind of when you can get over the counter, but they might be on that. Rheumatoid, methotrexate, or your DMARDs, so your disease-modifying anti-rheumatic drugs. Osteoporosis, your calcium and vitamin D supplements and bisphosphonates, and gout, they might be on allopurinol for prevention. And then lastly, just your social history. So this is basically same as all the other areas. So just your smoking, alcohol, and drugs, especially like smoking alcohol can increase your risk of autoimmune disease as well. Your ethnicity. I put this one in here. This is probably not something I did in phase 1, but something that I think is important to ask, especially with certain diseases, because we do have a lot of high-risk groups in Australia that can make them at increased risk. So whether you want to do that in your OSCE, I don't know, but I put it in there just as a thing to think about, even in hospital, just like identifying patients from different ethnic groups or kind of socially disadvantaged groups in Australia is really important when you are screening for disease and thinking about what might be happening. Asking about
Yeah, so how would you ask that?
Yeah, it's tricky, hey. I did toss up whether to put this in here or just put it at the start, like as a screening question. And I think it probably does fit better at the start, but it is a tricky one to be kind of trying to build rapport and just making sure you ask things in a sensitive way. But I think it probably does work better at the start because it can kind of frame your conversation and frame how you're thinking about things, and just if you need to be sensitive for particular topics. But yeah, I don't know how much you want to do that in OSCE, but probably just something to keep in mind going into year 3, that it's just a good thing to get into the habit of doing. And then occupation, so particularly with MSK, asking about has whatever symptom they've got been impacting their ability to work, what they're doing at work, and at home as well. So that's occupational therapy. There's a big focus of that in this topic because anything that kind of affects joints, mobility, is going to have a really big impact on how you can look after yourself and care for yourself at home, especially in the elderly. And that kind of goes hand in hand with your ADLs. So asking those questions and asking if they have support at home, if they're able to do everything, and just incorporating that. Okay.
Sorry.
Yeah.
So before as well, when you're asking just smoking alcohol, drugs in general.
Yeah.
You know how sometimes someone may say they're smoking a lot and stuff, and you're meant to be like, how do you feel about it?
Counselling.
Yeah.
It's tricky. I think for OSCE, if they want you to do what's it called, your motivation, counselling, they'll make that clear in your STEM. So yeah, it is tricky. You probably you can say something about it. Just say if you're asking. The other good tip, just in general, never say are you a smoker? Really think about your phrasing, because that can kind of just come across as a bit derogatory or judgmental. So always say, do you smoke? How much do you smoke? Clarify in packets a day, whatever. And then maybe just ask, have you ever tried to quit? And just keep it short, asking those questions, showing that you're thinking about it, but don't go into the full counselling unless it says in your STEM, do the motivational interviewing. Yeah. Yeah, have you ever tried to quit? And if it's yes or no, and how did that go? Or would you like to? Yeah. Any other questions on anything to do with history? Okay. If you think of something, we can come back. Okay, so I'll quickly just skip through this. So this is basically just your general exam technique. So you look, feel, move, and then the function. So in phase 1 function, you don't really do a lot, but I just popped it in there to be thinking about. So look, your general observation as with all your exams, and then when you're looking at particular body parts or joints, you want to be looking at like everything kind of surrounding that. So a good way to think about it is to think about the anatomy. So first looking at the skin, that's from like skin changes, muscle, any muscle wasting, the joint itself, and then thinking about like the ligaments and what might be happening there, and any nerves that might be involved or impinged by joint damage. Your feel, so same kind of approach, you can think about it in terms of the anatomy. So what are you actually feeling for? So with the skin, we always want to feel the temperature of the skin for any like inflammation. Muscles, again, feeling for muscle wasting and muscle bulk, making sure it's normal. And joints, any deformity, swelling, or pain in the joints. With your move, so we do passive and active movement. Passive movement is assessing your range of movement, and active is assessing their ability to do the movement on their own. So that's actually more testing for muscle weakness or nerve damage rather than you doing it. So in your OSCE, you usually do passive and then active first. I believe that's what Silas wants you to do, if it's the same as when we were in phase 1. In practice, you would usually do... Yeah, so that's what I was going to say. So in practice, you would do active first and then passive, because if you think about it, if someone can do something actively on their own with no trouble, then you wouldn't need to test it passively because it proves they're normal. Yeah. But I think because of the way, because they wanted to teach us how to do it, yeah, you don't do the active, you do the passive. Yeah. So yeah, just in case anyone asks. Because the tricky thing with OSCEs is doing what is set by the clinical skills guide, but then you're examined by doctors that might ask you other things. So just to be aware of, if you think about it logically, in practice you probably would do active first and then only do passive if there's an abnormality. But for OSCE, do passive. Yeah. Okay. So I just put these in here. Do you guys want me to go through this, or are you good with it? Just worry of time. So if there's anything you think you're fine with, we can skip over it. But these were just the deformities that are listed in the guide that you need to know, and they can be confusing, especially like the valgus and varus and remembering which is which. So I just put it in there. So I think the important thing to remember with these is that you're looking at the angle from the hip joint, and not so, even though we say like when we're looking at like the position of the knee, it's actually at the hip joint where you're looking at. So valgus is deviation away from the midline, so you can see up the top where it's got like the degrees. So it's actually to do with the rotation of the femur, and then the resulting abnormality, which you can see at the knees. And then with subluxation and dislocation, so subluxation is just a partial dislocation, whereas dislocation is complete. So you can see in the picture of the knee, it's got the normal one, and then the subluxed patella is obviously out of place, but not completely disconnected. Yeah.
Is valgus towards the midline?
Away. The picture, the degrees kind of are a little bit confusing in the picture, but
it's like not knees, valgus.
Yes.
But then isn't that, like, what does the midline mean?
So see in the, yeah, it's confusing. See in the middle picture, that's 0 degrees. That's where the midline is measured. So because you can't like see the rotation in the picture, they kind of look the same, but just different degrees. But with valgus, so the deviation of the femur is away from that midline, which causes the femur then to go in, and that's why it's you get the knock knees. So because it's in at the knees but out at the hip.
Right. Okay. So you say it in relation to like the.
Yeah. So it's in relation to the head of the femur.
But not in relation to the
No.
So the knees go towards the midline.
Yeah.
But the head goes.
Yeah. Yeah.
Can you define it as, because in hospital the guy was like, yeah, you define it as like the distal leg. So distal leg is deviated.
Yes.
forward.
Yeah. That is correct. It's very confusing. I think, yeah. Try and remember it the way that works best for you, but
Yeah.
it is confusing. And then there's like, this is like the deformity, and then you also have like valgus and varus stress. And I remember last year preparing for ICE, we had so many arguments over which way was which, even like amongst ourselves and with the doctors, because it's just, it can get very confusing. But I think for OSCE's like sake, just remember what they look like, because that's what you're going to be assessing at the knee. But then just knowing that it is actually an assessment from the femur if you're asked a question about why does that happen. Yeah, because otherwise it can get quite confusing. Yep. Okay. Exam. So what I was thinking is we'd quickly run through it and then have a go, if you guys are cool with that. So this is basically just going through the structure like what's in your guide. So first thing with MSAL, you want to do your move, so assessing your gait. So I've just put in there some of the things that you're looking for. So is the gait smooth? Is it symmetrical? The timing of the gait and of the kind of phases of gait. Is the step height normal or is it accentuated? Do they have foot drop? Any notable weakness? Again, valgus varus, and the arches. So pes planus is flat foot and pes cavus is high arched foot. And then some of the common types of gait you might see are your antalgic gait, which is like your limp. I've spelled that wrong, but that's Trendelenburg gait. And a Parkinsonian gait, which again you probably won't see because you're doing normal, but good to be aware of. And then moving on to the spine. So looking at the curvatures, so I think you assess from the posterior side of the patient first, looking at cervical, thoracic, and lumbar curvatures, and if there's any excessive lordosis or kyphosis, and scoliosis, which is your lateral deviation of the spine. Looking for symmetry, again at the shoulders and at the hips, is everything in line or is one side kind of up, and the muscle bulk, and then you test for flexion. So lumbar spine, which is where you're standing and doing the Chauvis test, it's called, with the two fingers bending over, so hitting the movement, and then your lateral flexion, where you're getting them to touch their head to the shoulder. Arms, so I kind of feel free to like move the how you actually do it around. The trick with is just like trying to make it like the actual order of what you're doing isn't too important, as long as you get it all done and do it in a way that kind of flows. So with the arms, you need to look at the hands and the shoulder, but then you have to like move. So to me, I kind of think if you do your like look and feel first and then do all your movements together, that kind of feels more natural to me. But if you have a different way, then that's fine. And just like the hardest thing about this screening exam, honestly, is remembering what's in it compared to the other exam. Like, I think that's the hardest part. Like, actually doing the exam is pretty easy, but it's just remembering what's not in this, that's in your hand exam. So if you just think about it, it's just a general overview, looking at your hands, feeling the MCPs, looking at the shoulders, and then just your basic movements, which are all up there and we can go through in a minute. And then with your legs, so looking, again, if you kind of do that before you do your gait, so make that at the very start when they come in, just say, I'm just going to have a look at your legs and then walk, then you've already covered that there. You can just get them to lie down straight away then, and it kind of flows more naturally. So then you want to be feeling for temperature, swelling, and the MTPs at the ankle for any tenderness. And then movement, you're doing hips, knees, ankles, so if you just think about it going downways. And then the last thing is looking at the feet for any calluses, which might suggest that they've got an abnormality of gait. Any questions on that? Who wants to have a go? We have 2 people come first. One person can be patient, one person can have a go. And like you can just use this to refer to, or I can help talk you through it. Cool. Okay, cool. So I'm sorry, but yep. So he's come in and he just wants to get a general checkup, and you're going to perform musculoskeletal screening exam.
Wait, so did you want to? Oh no, I do.
We'll swap.
Okay,
You can
sorry.
do. We'll do
Okay,
the
okay.
hands and so we're all going to turn. Yeah.
Okay, okay. All right. Hi there. My name is Anju. I'm a second year medical student from UNSW. Can I ask your name?
Michael.
Michael. Lovely to meet you, Michael. So today I've been asked to do a screening exam of your muscles and your joints. This will include me having a look, move, and a feel of different joints in your body. I might get you to stand up and move around for me. Will this be okay with you? Wonderful. So before we start, I'm just going to ask you, Michael, if you have any pain in your muscles, joints, or back at the moment?
No.
Okay. And any stiffness? Okay. And do you have any trouble getting dressed in the mornings?
No.
Okay. And how about any trouble getting up and down stairs? No. Okay. Wonderful. So Michael, I'm going to start by getting you to stand and move for me. Do you feel comfortable and stable, like standing and walking?
Yeah.
Wonderful. So if I can get you to stand up, and I'll just get you to stand there. I'm just gonna just take a look. All right. And so can I get you to walk towards me? Good. And then just turn around and walk back. Okay. Wonderful. So I'm gonna once again just take a look at you from the back. And yes. And now I'm just gonna come to the side and take a look. Okay, so Michael, I'm now gonna put my 2 hands on your back, and I'm gonna get you to lean forward as far as you can to see if you can touch your toes. So I'm just gonna start by. Michael has really strong back muscles, so it's literally just like this ridge, and I can't feel his leg. Anyway, all right, thank you. So leaning forward, Michael. Good, and coming back up. Okay, wonderful. I'm going to just come to the front. So can I get you to try get your ears to your shoulders, but without moving your shoulders? Good. And other side. Okay, wonderful. Yep. Now can I get you to, we're going to take a seat again. I will. There you go. Oh yes, and ideally I would have had the patient in like a gown.
Yeah. So.
Yeah. All right. Yes. So now I'm going to take a look at your hands. So can I get you to put your arms like this? Yes. Good. And can I get you to put your hands out in front of you like this? Good. And can I get you to rotate them out like this? Good. And then to the front again like this. And then can I get you to make a fist for me? Good. And then do this with your fingers. And then next finger, next one, and the next one. All right, wonderful. So I'm just going to have a feel for one of your hands, if that's all right. So just grab your left hand. Okay, cool. I'm just going to squeeze. Is there any chemicals here? Good. I'm just going to put it close. All right, and then the same with the other hand. Is there any chemicals here? Good. Yes, and can I get you to bring your arms up to here? All right, wonderful. Okay, so Michael, I'm now going to take a look at your legs. So if I can get you to lie down on this bed for me.
Knees are tricky.
Yes, no, thank you very much.
So comfortable.
Yes, and ideally I would have the patient exposed like up to the hip joint without shoes on. I'm not going to do that. Okay, so I'm going to start by just taking a look at your legs. Okay, and I'm now going to have a, I'm going to be on the right side of the bed. And I'm going to just have a move of your legs. Yes. you. Once again, this leg. Is that okay?
Yeah.
Alright. I'm gonna just have a feel for your kneecap now. And other side. Is there any tenderness? Okay. And I'm going to have a look at your feet. Just gonna move them. Same on the other side. Alright, I'm just gonna squeeze your like foot knuckles, I guess. Is there any tenderness? Okay, same on the other side. Alright, I'm just gonna look at the bottoms of your feet. Lovely. Okay, thank you very much, Michael. Do you need a hand getting up?
Yes.
Okay. Don't do this again. Okay, thank you very much, Michael. Do you need a hand getting dressed?
No.
Okay.
Okay, good.
Okay.
All right, we'll quickly go through it.
Yes.
Because we're running out of time. That was good. A few tips, just it's because you haven't probably had a lot of practice, but again, just being confident with what you're saying, which will help when you know it off by heart, and just don't feeling like you have to explain every kind of thing. So, for example, when you're doing spine, just say, I'm just going to place my fingers on your spine now, and can you bend forward for me to touch your toes?
Okay.
So just things like that, which will help with your like getting the speed as well. Otherwise, everything was good. You did all of that. Oh yeah. Do you do that in
I
school?
don't remember.
I think it might just be in hands and wrists. This is what I mean. This is tricky.
Yeah.
In the exam, if you do an extra thing, it's not going to be it's not going to matter anyway. It's more just your time. For the arms and hands, just making sure you're really accentuating looking at the hands and expecting for any scars or anything. You can feel like the thenar, hyperthenar, the waist as well, that kind of thing. If you're feeling really good, you can do cat refill just as an extra thing on fingers and toes. And then all the movement was good. When you raise your arms in behind your head, make sure they're just really raised, and then rather than just going like straight up.
Okay.
Because
that's for elevation.
and then the external rotation. Yeah.
Right.
And
Would you get the patient to still do it like sitting? Like just, I guess maybe they're probably sitting on a bed. It's not like
this is why this exam is just kind of structured very awkward. But they can do it sitting if they don't have things on the chairs. It's a bit easier. And then legs was good. Few things with the knees, which it's hard with pants on. So for your palpation, making sure you can check for your temp. I don't actually know if that's essential in this, but it is in the knee exam. So just like feeling down for temp, and then bringing the knee to 90 degrees as well in this, and feeling around the joint margin. So you do that initial palpation, and then with your movement, so you can actually do. So do you want me to jump down?
Sure.
That's all right. So you can actually do all at once your like knee flexion and then your hips.
Yeah.
To save going like up down. So
Yeah,
you can do you can go up. So that's your flexion.
Yeah.
And then you can do your hip rotation and then back down.
Yeah.
And then you've covered hips and knees both only in like that one movement. So it's a bit quicker.
Then because like your hand wasn't on my knee when I was like lifting it up though. So could you feel crepitus then, or is it only on the way
Yeah,
down?
it's like kind of like that, and then you can actually like lift it like that.
Right.
Yeah.
Right.
And then ankles and everything was fine. Cool. Yeah, that was basically the only thing. Yeah, just makes it a bit quicker and look a bit smoother, and then you do it once on either side.
Yeah.
With crepitus, it just reminded me, just like knowing if they ask like if they've got crepitus as a positive finding, it's very non-specific. Like it but it can also happen in normal healthy individuals. Just as a side note.
Because it's probably like OA.
Yeah. But then it's like half the time you'll do it and like you'll have crepitus and you're like, oh, but you don't have arthritis. So it's very like it can be with other signs, but it's not necessarily that specific. Sorry, you can jump up now.
Could you do like an example of like summarizing?
Tricky. I have a summary slide at the end with some like notes rather than me trying to do it to my head. But yeah, I have an example for you to read.
Yeah.
Okay, let's quickly jump to the next one. Gosh, time goes really fast. Do you want to do hands and wrists first, or actually let's do it and we'll just go through the parts that weren't the same as MSAL. Does that sound okay? And you can have a quick go. So you'll look basically all the same things in your hands. You can check the elbows as well for rheumatoid nodules. You can sometimes get nodules underneath there. And then, your asymmetry, so your prayer and inverted prayer. The hardest part about the palpation and movement in this is making it not look awkward because it's really tricky. So it's just like thinking about it systematically. You're just doing there. And a good way to do it, I'll just borrow your hand, is to kind of hold the patient's hand like this and use your two thumbs to do it. So because they kind of sometimes does it like this thing, but it's really awkward. So if you go like this and then you're assessing each one. And the other thing is as well, which I know you're not actually like feeling on top of you're actually meant to be feeling in the joint space, not on like the actual bone. So feeling in between there for any pain, and then do your so I like to do that palpation and then the movement for that joint. So flexion, extension, and then your deviation, and then move to the next one and do the same thing. Joints. I was definitely feeling on top of it. Yeah, I know. And then your flexion, extension, and then same for each one. Yeah. So that way, and then like it's really quick, and then you've done all of them and your movements all in the one go, rather than like otherwise you like feel here, then you feel here, then you feel here, then you go back, and it just kind of feels a bit awkward. And then the functional tests. So we'll quickly go through them. So your grip strength is this one. Getting them to grip. Now with the pincer and opposition, so the way it's taught in phase 1 is to do the like this and then break it apart. That's actually not very good. And I would do it this other way because like this is how like most people, and if you can explain what you're doing, it's fine. And also in phase 2, they teach it this other way because it's correct. So basically when you're doing this, you're not really testing their strength because anyone can just like kind of pull through that. So the better way to do it is to do this. Sorry, your head's good, so you get the grip. So get them to do that, and then see. So you would do that, and see if they can pull apart. So if they've got reduced function in their because they won't be able to do that, and same thing with opposition. So instead of just getting them to like rip through your fingers, you're actually getting them to use those fine muscles and to actually do that. Does that make sense? So it's instead of like pull through my fingers, it's just can you separate my fingers?
I thought we
I thought we pulled through theirs.
Sorry, yes, we do. But that's sorry, yes, that was my point. So that's not like testing their. So if we're pulling through their fingers, that's like you can just rip like, you know what I mean? Like you're gonna be able to pull through anyone's fingers. Yeah. So it's not really gonna differentiate who's weak and who's strong because you just don't have decreased strength, but I can do that easily. So if you're getting them to do that, that's testing. We're around the right way. We're the opposite. I'm confused myself now.
Do the patient to do that, and then you want them to try to pull it apart.
Sorry. Yes. Yeah. So seeing if they can hold it together. Yes. Sorry. That's correct. Yeah.
But either way, you're going to be able to pull them apart. But like, it's just seeing if that's different.
Yes. Yeah. It's just a little bit more sensitive than ripping through. Actually. Yeah. Sorry. Okay. Do you want to have a quick go? Yeah.
So just the function bit.
Do you want to just go from the like palpation and function, and you have practice? I can do the palpation if you like.
Yep. Sorry, I'm gonna heat up my food because I've got class.
The other thing is as well, don't be like afraid to get too close because you really have to in this exam.
Yeah.
And usually you have like a pillow, which is nice.
Yes.
Easy for them to stand.
Yeah, that's easy.
Yeah.
Alright, so hi, I'm Sarah. I'm second year medical student, and today I'm going to be examining your hands and your fingers. This is going to involve me moving and feeling and looking at your hands, and then doing some factual tests. Is that right with you?
Yeah.
And do you have any pain before we start? No. Alright. So first of all, I'm just going to take one of your hands. Yep. I'm just going to feel your wrist. Do you reckon you should then do the other hand? To like
Yeah, you
compare?
can. Yeah, to compare.
Okay.
Yeah.
Right.
Don't be afraid to go hard as well.
Harder?
Yeah.
Okay.
It's always like you're always so
Yeah,
timid.
don't
Yeah,
wanna,
just like
hurt them or anything.
yeah.
Yeah.
yeah, and it's like you ask about pain at the start, and yeah, they'll tell you. Yeah.
Okay. Right.
Yeah. So you can.
Yes. Alright. So, can you grab my two fingers and don't let me pull them out? Good. Okay. Now make a circle for me. And don't let me pull them apart. Good. Can you do the same? Yep. Yeah, it's hard, isn't it? And then right
Oh,
on.
if I'm sure to do that. Yeah,
Yeah.
my little trick is I like to get them to take off my watch and then put it back
okay.
on. That's just one of the things. You always have your watch on during an exam, and you can just be like, "Can you take my watch off for me?" And then they take it off, and they're like, "No, put it back on." They always have a bit of a laugh. So that's like what I like to do for that, and it's using those skills.
Okay.
Cool. Okay, we probably have like 1 minute left.
Yeah, I'm always confused with watch because they're like bare below the elbows.
Pardon?
Because they're like bare below the elbows.
Oh, true. Yeah. Yeah. If that's the case, then usually they'll have something there for you to do. Yeah, and like they say for guys, you can get them to undo a button or something. Girls don't usually have buttons, but yeah. Anyway, just like some little thing, or get them to write their name or anything like that. Works the same. Okay, we won't go through this because I can give you the slides and you can have a read. This is just the different things you're looking for. we will try and do knees in like 2 minutes. Okay, so I can just like talk you guys through it if that's best.
Yeah.
So you want to look first. I think in the guide it has gait at the end. I prefer to do it first because then you can do the introduction. You can say, okay, do you mind just standing over here for me? I'm just going to have a look at your knees. And then you look at the legs overall, then focus on the knees while they're still. Do your anterior, lateral and posterior, and then get them to walk and assess their gait. Same as we did in MSAL. And then you can get them to sit on the bed, lie in the bed, and then they don't have to get up again. So it just works a bit better. So again, exposing patient up to the top of the thigh, feeling down the leg for any temperature changes, particularly of the knee. Then you flex the knee to 90 degrees and are feeling around that joint margin for any tenderness, palpation. You can feel the patella as well. And so then the test, so you've got your patella tap test first. You're just compressing down the suprapatellar pouch. So the idea of that is if there is swelling, you're pushing the fluid in. And then you just want to press onto the patella. So some people do this or whatever, but you just want to do a slow kind of press, because what you're feeling for is if there's fluid underneath, so the kind of patella is floating above the kneecap on that fluid. And then after you've done that, you do the bulge sign, which is the same thing. So compressing suprapatellar pouch to get the fluid in there, and then you do medial first, and then lateral. And so the idea of that is if there is fluid, you'll be moving it, and you'll see it come down on the other side.
If the patient's in pain, do you still move their limb around and stuff like that?
To a certain extent. It's you kind of have to. Even I remember the first time I examined a wrist of someone with a fracture, and I was going so soft and so scared, and the doctors come in and they're just they're a lot rougher. But you kind of have to, because you got to remember you're actually assessing them, and if even though it will cause them temporary pain, if you don't assess them properly and you miss areas that are painful, you're going to miss what the problem is. So it's kind of being building that rapport enough so that when you are pressing on them and they are in a bit of pain, you're sorry, I just need to check this. It won't be long. But particularly with joints, actually I was going to mention that before, probably not as necessary, you're not doing a hip exam specifically, but just make sure you always ask, because if someone's had a hip replacement, they actually can't hyperextend their hip. It can be really bad. So just those screening questions, have you ever had surgery or hip replacement or anything like that quickly? So that, and then feeling at the back for your Baker's cyst. And then movement, we quickly went through before, just your flexion, extension, that's easy, feeling for crepitus. Then you're doing the ligament test, so the collaterals. So are you guys, how do you feel about that? Feel okay with that? Holding one, pushing the other way? Yeah. Just making sure it's at the right, you got to flex the knee a bit before you do it, so it can move. And then your cruciate ligament sitting on the foot, push forward, pull back. Yeah. That's basically it. So the knee's actually really good. It's a good exam to do, and if you just think about it systematically, the ligaments is probably the hardest part, but if you just get that technique down pat, then it's not too bad. Oh, sorry, I think I did put that in there. I forgot to say it somewhere. Yeah, medial lateral patella movement. Yeah, moving it to the side. And that's one thing as well. If they do feel pain there, do be careful with the patella, because apparently there's another test you'll do in year 3, the patella apprehension test. And if someone has a dislocated patella, it's it's literally called that test because they will scream at you if you try and do it, because they have this sense of impending the patella's going to dislocate. It's crazy. So just making sure you do that carefully, and just always checking before you do it. Okay, and that's a summary of the different ones and things that you might say. Just one thing I would say with, especially with MSK, just be careful of practicing this too much because even though you will have normal patients, you'd probably guess that 90% of the population, even if they are normal and healthy, have some kind of MSK abnormality. Like it's really common, whether it's like slight asymmetry or whatever it is, that you probably will pick up something, or crepitus or anything. So like practice that, but just remember that you are likely to find at least something, and just be careful not to fall into that trap of having rehearsed it so much that when you get a finding you like freak out and forget and don't include it in the thing. But that's kind of your basic overview of how to summarize. And yeah, it's basically just going through what you did in that order and saying any important findings.
What is cadence?
Just like your speed.
Oh.
Yeah, the timing. Yeah, like through the phases of gait. You've got like your step phase and yeah. Yeah. Any other questions? Sorry, that was so rushed. There's like a lot of exams to go through. I hope that was okay. Cool. All right. Is it easiest way if I send the slide to you guys and then you can distribute? Yeah. Okay. Cool. All right.
10 skills, woo!
You'll be totally prepared.
Yes, I'm actually so prepared for MSAT.
Yeah, and you can click
Stop. Yeah.